I do. Now, I sent you an email, was it last month, about with a few questions? Yep.
Yeah, I got the 6 questions in front of me.
Sweet. Yep. Okay, so if we can start. So first, before I start with question 1, can you just explain your role a little bit?
My role?
Yeah.
Okay. So I'm a remote area nurse in a remote Aboriginal community. This is a role where in these clinics you often don't have medical services, as in doctors, and you are providing all care to the whole of life to a remote Aboriginal community in a remote isolated district, and most of your resources are a long way away. Background, I don't know if you need that. Basically, I've been doing this job for 14 years, and prior to that, I've been a nurse for decades, and my background was ostensibly ED.
Great. And with the 14 years as a remote area nurse, in the community that you're in at the moment, how big's the community? What's the population?
Okay. This particular community I'm working in at the moment is about 300, maybe 350. As you know, the number of people in a community varies greatly from week to week, depending on funerals, depending on holidays, depending on lots of things. And I have worked in, over the 14 years, about 35 remote communities, ranging from very small communities of about 50 people up to the biggest in Australia, which is Maningrida, which is about 3,500 people in a community.
Yeah, wow. Okay, so with the community you're in the moment with 300 population, how often is there a doctor with you at the clinic?
Yep, okay, so current GP modelling of the world says you should have 1 GP to 1,000 people. Mm-hmm. We are typically, just like most remote areas, and very understaffed with GPs. We would normally, and this is not what we've got at the moment, we would normally have a GP visit us from Kununurra, which is about a 40-minute flight, twice a week, Monday and Wednesday, for about a 4 to 5 hour clinic. So that's 10 hours a week of a GP, which is about half what our population should be getting. And at the moment, right through January, we've almost had no doctor visits at all because the shortages in Kununurra of medical staffing, which is a town, means that they have no staff for outreach, which means we don't get anybody.
Yeah, wow.
So we do have telehealth though, and that does get utilised. So we have a doctor that we can look through a television screen at and have a consultation with. And we also have obviously 24/7 doctors available by phone for us to consult with.
Okay, and those doctors that you consult with 24/7, are they in Kununurra or are they in...
For this community, yes, that's correct. We always go to our receiving hospital, which is Kununurra, to speak to the doctor first, and depending on the acuity of the patient or what the problem is, that'll then either be escalated to RFDS, be escalated to Broome if it's paediatrics, or just be left with Kununurra and transferred to Kununurra.
Yep, sweet. Cool. All right. Well, thanks for the background of where you're at. So just to start with the 6 questions that I gave to you a bit earlier, if we can start with question 1, what principles guide your care as a nurse with Aboriginal and Torres Strait Islander people, community members and their families?
Yeah, okay. So looking at all your questions was quite interesting, and I must admit I did enjoy your article because it does reflect relatively well on the kind of patient-centred sort of thing that we're trying to achieve. I guess the principle, I sort of try to break it down like this. So I'm a nurse and I'm delivering a Western medical model in a culturally safe way. So it's a patient-centred approach, and that's basically because if you have no engagement with the community, then you'll have no buy-in to the health, and therefore you'll get no results. It's a bit of a balance, so it's a sort of multifaceted sort of thing. So cultural safety is number one. How you, if you're not culturally safe, first and foremost, you'll never get really very much ground traction at all.
Yeah.
And that means, when I say cultural safety, there's a lot of things underneath all of that. But the rapport that you can get with the ATSI people, wherever you are, how you can translate the medical knowledge that you have in a way that satisfies their need, and then getting you to a point where you can agree a plan that is medically sound. I think it's quite interesting experientially. 14 years I've been doing this, and the way I approached it 14 years ago is very different to the way I approach it now. 14 years ago, Julie, who is my wife, who's also a RAN, would tell you very funny stories about. I came in as a medical person from a very strong ED background, decent hospital size that had FACEMs and very ED approach. So if you had a sprain to your ankle, I would give you a medical breakdown of what the ligaments were and that you needed the treatment right, and give you a very long-winded medical explanation of what you needed to do for aftercare, handouts, etc., etc. And I would talk to you in English that was hopefully not too medically jargony, but would still be fast speaking and would probably be quite an extensive, communication about your ankle.
Sure.
And that is just so inappropriate. I think it's quite extraordinary to see how you need to simplify your language. You need to build connections with people. You need to learn stories that work with the local population, and you need engagement. If you don't have engagement, you won't go anywhere, and that's what cultural safety is all about.
And how do you actually start that engagement when you go to a new community? So there's many different ways that people approach this. There's a lot of communities that I've been back to repeatedly. So you need to learn who's who. You need to learn families. You need to learn out who's connected to whom. You need to often go and introduce yourself to people in the community that are seniors. You need to approach the whole process with the concept of understanding that you're in a position of power being a nurse in a remote community. And the problem is that that's viewed very differently by the local population. So you need to try and remove some of those power discrepancies between you and the population. So yes, you're providing Western medical services, but you need to do it in a way that is understood around the culture that you're working with. So it can be as simple as what you wear. Wearing a uniform is almost never done in a remote community. You will wear clothes that are very conservative, clothes that don't necessarily show that you're not in a uniform per se. You're not wearing the corporate shirt. You're not wearing things that will make you appear to be in the position of power. Sure.
And then, of course, it's about communication. So it's about how you initialise a consultation. It's about how you manage the consultation. It's about how you finish the consultation, and recognising some very big differences between me as a person and the person you're working with to try and achieve a health outcome. So, recognising that confidentiality works differently, working out that, there can be lots of other views on what good health is that isn't the Western medical system. So recognising all of that, but then still recognising that, you're there to provide treatments that may save a life, and that needs to be put across in a way that you can get engagement, that the other person is interested in doing it this way for the reasons that you've been able to work with them to get it to an agreed position.
Sure. Okay, so with all that in mind, 14 years ago you treated somebody with a sprained ankle from a very Western worldview, how would you treat a similar sprained ankle after 14 years of working as a RAN? How would you do that now?
Yeah, you're going to be using a Western medical model of consult, so you're going to be still assessing the injury in the way that you would still address it anywhere else. The differences are in how you're going to communicate that and how you're going to get engagement from the first second that the person walks in the door. So you may not be going in, you bring someone into the room, you're not going to just jump in and start looking at the ankle and dealing just with the ankle. You might actually take time to work out who the person is, who they're connected to, who do you know in common, finding some commonality, whether you know that the person they've come with might be somebody that you've dealt with before, so you're going to build bridges with the family that's come in. You've got to recognise that consultation is never one-on-one generally, because families are absolutely essential to the process, and confidentiality doesn't work. In culture, you don't. If you had a broken ankle and I'm dealing with you, and I've got family there, I don't leave them outside. I don't leave them in the waiting room while I consult with you. They come in. We all do this together. I don't hide information. I don't hide what I'm doing, no, because that is how it's perceived. If you separate people from their family to try and treat, then that will actually create very big problems. And it could actually lead to D for danger for yourself if it was a big case. Not an ankle, but if there was alcohol involved, if there was an arrest or something like that, if you try to manage these things in ways that you do in a hospital, that's not going to work. You need to be able to have the whole family involved. Confidentiality often means that you're discussing the whole plan for the patient who's in front of you with their entire family in the same room.
Sure.
And that's okay. That's the way it's meant to be.
Yeah.
So, and the language you use is, you need to learn how to translate medical jargon into something that a person might understand, because it's if I gave an example, might be a better way to do it. So I can tell somebody, your sugar's high, and it's as in your BGL's high, and it's going to hurt your kidneys. Okay, now that's a nice straightforward sort of concept that, if I said that to a Caucasian person, they would go, all right, okay. And the reason it does that is because, it damages the vessels that are in the body. Now, I think one of the easier ways to describe this is when you're having a consultation with a person from an Aboriginal community, you might do it in more the terms of a story. So, for instance, the sugar that you eat, the one that's in the drink that you've got there next to you, that gets in your body and it goes through the pipes in your body where all the blood flows. It's like a river. So, and the sugar in the river, as it goes through those pipes, it's like steel wool. And the steel wool will scratch all the inside of your pipes all over your body because of the sugar that you've got. So the sugar is the steel wool. Now, you've got to remember that you've got big pipes and you've got little pipes. And the big pipes, are in your heart, and the little pipes are in your kidneys and your fingertips and in your eyes. So if you put steel wool through your body for a long time, then you can end up like those other people with sugar disease that you've seen, that, they don't have a leg anymore because the pipes in the very small pipes at the end of the leg don't work anymore, so they have to be cut off. Or it might mean that you have to have that big lump in your arm where you have to have dialysis because your kidneys, which have small pipes, they've all been ruined by the steel wool as well, and so forth and so on. And you can imagine the story. So you can have a story which explains it in a very visual way, or you might use other sorts of tools as well, like visual things to show someone, a normal score is 4 to 8, but when you're up above 16, it's an unhappy face, versus if it's, only 10, you're getting really close to being in the happy zone, so you can have lots of different sorts of ways of describing things. And I think it's about actually trying to work out how to put the medical jargon. You're not going to talk about ligaments. You're not going to talk about muscles. You're going to talk about how your ankle's fat because it's been injured. If you lift it above the level of your hips, pointing to the hips, then your ankle won't be fat anymore. It'll get thin. If it's fat, it hurts. If it's thin, it won't hurt. And that makes things, it's the way you're using English to describe what you're doing that gets the person to understand a lot quicker, and it gets engagement because they know what you're talking about.
Yeah, great. Okay, well, thanks. Great analogy with your diet with sugar being like a steel wool. I quite like that. I haven't heard that before.
There's over time. I'm sure that everybody does this. Well, I don't know. I do. Julie and I talk about it all the time. But you work out a range of stories for all the different problems that you're facing. And it's actually important to have the slow discussion, because it's actually, you get better engagement by having communication where you're being understood. You're certainly not using medical jargon anymore, and you're not speaking the way I'm speaking to you now.
Sure. And you mean by slow discussion, you mean you have time of silences and things where the community members will actually start absorbing what you're saying?
It's important to listen. It's important to wait. It's important to pause. It's important to allow... You've got to consider that English is often the second language, so just like for any other culture on the planet, most people, when they hear English and it's their second language, they have to actually translate it in their head to their own language, think about what you've said, think of what they're thinking in their own language, and then translate it back into English to talk back to you. So that whole process is not something that just is instantaneous. There are plenty of communities where English is very strong, and there are quite a number of communities that we've worked in where English is a third or fourth language. So you have to really judge by your engagement whether the messages are getting through and whether you're allowing enough time for the person to ask questions, consider what you say, and pausing is really important.
Yeah, sure.
But so up in say, for instance, the Northern Territory, so where we were in last year, which was Yolngu country. There's Yolngu language, and you can become a lot more needing to learn words to be able to understand. There are certain medical words, like understanding that urine is gumbu, poo is guna, in other languages, menmak means thanks, and, just lots of different words that you pick up along the way. It's not about whether you can speak the language fluently, because you won't be able to. That would take a long time to learn. It's about being accepting that you need to take the social mores, I guess. So if someone introduces themselves and uses language, then you should learn how to respond back quickly. And you need to allow, that's the way they talk to each other. So, but you can pick up a lot by just listening.
Yeah, cool. All right. Have you experienced any barriers when trying to build trust with community members? And if so, how did you overcome them?
Well, I think there are lots of barriers. I think, first and foremost, being a male, recognising that some of the first barriers that occur, people will always say that, females like to talk to females, like to tell females women business, men like to talk to men to talk about men's business. This can be some of the barriers that occur. There can be barriers with culture. in terms of, when you're trying to get an agreed medical plan with somebody. For instance, if you have someone who is sick and the medical model tells you that they should go to hospital, there can be a lot of barriers to a person agreeing to go somewhere else because of their family commitments, because of the fact that they have fear, because there could be other things that they're not, not happy about leaving, like they might not want to leave their partner because of the jealousy or something like that. There are many different approaches to many different issues. So, for instance, some of them have straightforward strategies. So you have a child who comes in who needs a needle for skin sores but doesn't want the needle. And the parent is not going to force the child to have the needle. They'll ask the child to have it, but the child might say no. And then that presents you with a problem because the child needs the needle. The parent wants them to have it, but can't force the child to do it. And the child says no. So you have to consider how to work around these sorts of barriers. And that, in that particular circumstance, getting the father of the child, who might not, the mother might have brought the child to the clinic by themselves. So getting the father to come to the clinic, or getting the grandfather or the senior male in the family, these sorts of things can, there can be a power discrepancy in the family, so that it's the male who can tell the child this needs to happen. You can go down the pathway of getting parental consent to get a couple of nurses to hold the child while you do the treatment. So parental consent can be sought, but sometimes it's really important to actually get the whole family involved, because that's how you get the outcome that is actually best. So, for instance, if a person doesn't want to go to hospital for a reason, having the whole family in the consultation room to discuss this and why the person needs to go, and allowing the family to convince the person to go. For instance, there are some issues, for instance, when you have a death, that you attend a death somewhere in community, it's really important how you are communicating with the family, and that culturally you should understand that you should not be saying the person is dead to anyone there. It's actually important to actually seek out the senior male of the area to tell them what is going on, so that they can tell the rest of the family, because that is cultural safety. And if you approach these things the wrong way, deep for danger, you can be putting yourself into pickles that you shouldn't have to put yourself into if you've actually learned how the culture wants things to be managed. You need to approach things the right way.
Sure.
There are other interesting barriers. So you'll have people who are recalcitrant. They don't want to have a treatment. They don't want to go somewhere because and so because of that, you're in the invidious position that if they don't go, they're going to get worse, and that will then be something significant. But they don't want to go, and you can't convince them. So you have to learn other ways to approach and do it in a way that uses the culture. So, for instance, in Aboriginal culture, blame is a very significant strategy. So if someone has a bad outcome, there must be blame. Something is responsible for that.
Sure.
So if you have a recalcitrant patient who you've negotiated, you've gone through family, you've gone through senior males, you've gone through all of the normal approaches, and you have someone who is not wanting to still go down the best pathway, then actually recognising that you need to actually discuss with them that we won't take responsibility if you go and things get worse. It's important to recognise that sometimes showing them that you are, in essence, getting them to sign you're doing the whole thing that you would do in a hospital, like release against medical advice, but it's the way that you do it that actually is most likely to get reconsideration from the family and from the patient to that this is actually something really important because you've actually culturally addressed it in a way that shows them that you know that you have to go this far to get them to recognise that this is a dangerous thing that they're doing and that whatever reasons they're using to not go, they need to possibly reconsider.
Sure.
But then on the other hand, sometimes you have to do the other way, which is you've got, say, a patient who has an appointment but has come to you and said, look, they just can't go. Now, you really need to advocate and get things rescheduled for people because there are lots of reasons. You might have an appointment where the hospital's got an ultrasound appointment that's only available once every 2 weeks and it's coming up on Tuesday, and now the patient can't go and they're going to lose their appointment. So it's really important to advocate that, they can't go because there's a funeral in the community. So therefore, their family commitments are far stronger and far more important to them than attending a medical appointment. So therefore we need to reschedule it. You need to be the advocate that stands up for them in the modern medical system that doesn't work well with people who don't attend things. So it's actually about trying to work the other way and actually advocate for the fact that their culture is very important. It's all about, not everything in medicine is urgent, and priorities are very different when you actually start recognising that Aboriginal culture is not Caucasian culture. Our culture is valid, but it doesn't mean that you should be ever putting your bias of the Western medical model onto a different culture. You need to actually get the agreed position, which is where there's a balance between what is culturally appropriate versus and being culturally safe.
Yeah.
That's probably a bit long-winded, but anyway, there you go.
No, it's good. It's great. So my next question for you is, if you were to mentor a health professional, so if you were to mentor a health professional who's not worked with Aboriginal and Torres Strait Islander people before, what are 3 key areas of advice that you would give them?
Yeah, that was an interesting question. I'm trying to put together 3 words is sort of so hard, isn't it? The 3 words I chose was compromise, respect, and taking your time. Now, I think the time is taking time. You need to have time to learn your medical stuff, and you need to also have time to learn what cultural safety actually means and how it is used daily. You need to take time to listen, and that's to recognise that the culture, the Aboriginals want help from you, but only if you can show that you can deliver it in the right way. So listening is really essential because that gets you engagement, and engagement means that you get positive medical outcomes. Respect. It's all about your own bias versus culture. Everybody's entitled to your own worldview. Everyone has their own culture, and it's very valid. But working out here, it's not about you. It's actually about delivering a Western medical model that aligns with the culture that's here in this community. Not the culture in the next community, not the culture in a city, and it's certainly not about you. You have to separate yourself from that equation because it's actually about showing your respect that your bias is actually not important. It's actually about doing it the right way. And then compromise is all about, recognising that just because you've got all this lovely medical knowledge doesn't mean that you're going to get that outcome at all on any specific occasion. And you actually need to recognise that you need to work out the boundaries. So you need to work out how to get to a compromise, how to negotiate, how to do it correctly, and then also know where the boundaries are that, no, that's beyond what's good, we need to actually do it this way or whatever way, and then learning what that means. And that, that's experiential, so it takes time to do that. I don't think it's something which, a new person can learn, but they need to take time to learn these things, show the respect through the process, and recognise that compromise is actually absolutely essential on almost every area, every day.
Great. 3 actually really great words. Did you have, talking about you don't think somebody who's just entered into this sort of as a health professional the first time they've worked in an Aboriginal community, how long did it take you to feel like you had a good equation or a good working relationship with Aboriginal communities? Were you mentored into the role, or was there courses you could do, or it was just through experience?
I think things have changed nowadays. So my first contract remote was back in 2006, and in those days, in my first contract, I was sent to the clinic. It was a 2-nurse post. I was the only nurse there, and I was on my own for about 3 weeks, and it was a really big learning curve.
Yeah.
I think nowadays, you can do postgraduate studies, that prepare you for remote work. And there's lots of short courses that are very useful for training your medical knowledge up to the skill level that you need it to be. Whether you call that doing immunisation certificates, whether it means doing REC courses, ALS, all of these sorts of things. I personally think it took me about probably 5 years to get a real understanding of what it meant to be culturally safe and do it in a way that was effective. Now, I'm a male and I'm probably not the most intuitive person, so I think I talk this out with my wife, who's also a remote area nurse, so I debrief every day. She happens to be particularly intuitive. I'm particularly not intuitive. I'm a person who's got a medical brain, but I've had to learn a lot of things along the way, and reflect on how I go about my business, because you make a lot of mistakes before you start getting it right. But I think you could do it. If you were a very intuitive person, you'd do it faster than that. But I reckon it was after about 5 years I really started to sense how from day one you should be approaching this to be able to actually be effective.
Yeah. Okay, so my question for you then, in that first, and this, I promise this is my last question, in that first, I've gone off track a little, the first 5 years when you say you were learning and you made a lot of mistakes, was there any time that you've worked in a clinic where you actually no one came to the clinic because you've put a foot wrong, or you've approached it all wrong?
No, I don't think I've... What we've found is that sometimes I can think of one particular occasion. So without revealing, client details or anything like that. So we had a death in the community. It was sudden. It was a child. It was it was a medical reason, but it was quite out of the blue, and the community, rightly or wrongly, it was wrongly, because there's a lot of other things in behind that, but medically, but the community felt that it was due to the medical treatment. Now, that did change, because, there's a whole story in there which we don't need to go into, but there was a short period after that where there was almost nobody coming to the clinic for a couple of days, which is also quite common whenever there is a death in the community. Healthcare at the clinic is very secondary to family. So if there's a death in someone's family, then the family will all go to be with each other, and attending a medical clinic becomes a very second or third option. They won't come unless they really have to.
Yeah.
But we had that happen to us. But then, as it became obvious that it was a different issue that had caused the child to finish, the community started coming back to the clinic quite quickly, and it was all back to normal very quickly. I think what you find is it's a one-on-one thing that you'll find. In the early days, you think you've communicated properly, but then over time you realise it's this switching off that occurs in the consultation. You'll see the person switch off, and you know that you've lost them. And I can only describe that because in hindsight, I know what I see nowadays. Now, I don't see a lot of that anymore, but I know that I saw it probably when I was in my first few years of doing this work. In hindsight, I can see, I wasn't getting engagement. I wasn't understanding what I was doing wrong. And as the years go past and you do more and more things, you begin to realise, well, that wasn't really the smartest thing to do. You were trying to do I had my heart in the right spot. I just didn't know how to actually
approach,
work with the culture.
Yeah, great. Excellent. All right. Well, I think that's all the questions I have for you, and thank you very much for sharing such an in-depth knowledge. All right, I'm just going to thank you very much. I'm just going to stop the recording now.